Thank you to Mr. Rathinam and to the organizers for inviting me today to give this talk. It's a rather very large topic, and radiologists and surgeons work very well together in my trust and in my hospital. I think that's the very reason we're here. As requested by Mr. Rathinam, I kind of focused more on oncology imaging, although I realize this conference is pretty vast, but just in order to kind of make it within the time. I'm one of the cardiothoracic radiologists, have been doing it for about 17, 18 years. Okay, so my talk is going to be really based on, it's going to be modality based. I'm just going to show you lots and lots of pretty pictures, and then we're going to see all the different imaging modalities and how radiology plays a role in virtually any imaging, but I'm going to stress mainly on oncology. So plain radiographs, as you know, it's most widely available, easily accessible, gives a, you know, and you incidentally pick up a lot of nodules. The sensitivity is pretty low, as you know, but because it's so readily available, there you are. So the most important thing here is that it's for each and every case, we still use it as for preoperative assessment for fitness. So that's just what a standard normal chest radiograph looks like. We still in some centers do a bit of lateral. I'm not going to dwell into anatomy, but that's exactly what it looks like. And when it doesn't look normal is such as this, where it's a huge right hilar mass, or in another incidence where the hawk-eyed ones may have picked up this non-specific right lower lobe nodule. I want to just keep most of these images in sight, because as we keep going through the specialties, I will bring back these same cases again. Then another example where there is a bit more prominent nodule in the right lower lobe. And another example, this is pretty barn door, where you see a chest x-ray on this side, whereas reconstructed coronal MIP images of CT on the other side. So you can see that there is a widening of the right paratracheal stripe, huge bilateral hilar adenopathy, and you know, that's really it, which shows again a very abnormal x-ray. Now that shows the limitation of chest x-ray. You can see this kind of nodule in the right mid zone, but when you see it on the reconstructed MIP images, you find there is a much larger subsolid nodule and a nodule even on the opposite side, which is not so well demonstrated on the CT. Another classical example, this is from last week's MTT Raleigh. As you can see, this was an incidental pickup of a right lower lobe lesion. This was from 2014, and in the year 2021, you can see that this is grown in size. This was not so easily picked up. And that's what the problem about chest x-rays is. You don't really often pick up enough because it's hidden behind certain, especially in busy x-rays. It's increased, and it was found to be a slowly growing adenocarcinoma. So another example of a non-specific right lower lobe, in fact, the hawk-eyed ones may find that actually the lesion is right lying at the anterior end of the first rib, which on a CT is shown to be a small T1 lesion. This is a pretty obvious one, right upper lobe mass lesion, the golden S sign that you might be familiar with a huge mass lesion, which on a CT is shown to be occluding the right upper lobe bronchus with extensive consolidation in the upper lobe. Okay, this was an interesting case. This lady, for the ones who might have picked up, is where you find that she's had a mastectomy on the left. And believe it or not, this was actually a malpositioned breast prosthesis, and the x-rays hadn't changed over years, but the lady was having hemoptysis. So the CT actually showed that there was a lesion behind the prosthesis, and that was found to be an incidental lung cancer. Just shows the limitation of a chest x-ray. Then another example where you found some non-specific shadowing in the right mid zone. It was thought to be probably non-specific infection, was followed up 6 weeks later, which is a standard protocol. It showed a slight change in morphology. It showed slight change in morphology, but it continued over a period of 3 months. And the CT then showed that it had a characteristic bubble appearance of what was thought to be an adenocarcinoma, proven subsequently on biopsy. So that brings us to the next modality, which is CT. Again, widely available. It's got a high spatial and temporal resolution. Of course, it uses a lot more iodinated contrast and is almost invariably used in the next step in the staging process. So here is the first case that I'd shown you there, where there was a right upper lobe mass, which on CT and coronal reconstructions here, you can see it's a pretty large. It was thought to be well above 5 centimeters, and the fat plane was preserved and was thought to be a T3 tumor. The non-specific shadowing that was shown previously, when on CT, was shown to be pretty non-specific ground glass shadowing, and there was an incidental nodule that was picked up here. This, in the same patient as this current one, was shown to be having multiple PEs, and yet this nodule was thought to be a bronchoscele, because when you can actually gauge even though we see everything in gray, you can actually gauge the Hounsfield units, and that was thought to be negative and consistent with the bronchoscele. So that brings us to the next thing. So what is all this about? Well, ultimately, we are doing this all with a view to stage, and the staging is done by the TNM system. I'm not going to dwell into, again, the details of it, because you're all familiar with it, and CT is pretty good and sensitive predominantly in T1, but not so good in the N and the M stage. So just a couple of examples. This is a tiny little nodule which was seen in the right apex, and that was thought to be a T1A lesion. Another lesion, which was a bit bigger, 1.5 centimeters, thought to be T1B lesion. And the same example that I showed previously was thought to be 5.5 centimeter. The fat planes were preserved. I've just done a single coronal reconstruction, was thought to be T3. And that particular case that I showed you of the right upper lobe blockage with the golden S sign was thought to be a T4 lesion. That brings us to the lymph node stations. So why are the lymph node stations important? Well, I think the most important thing about radiology and surgery, or for that matter, with putting the patient in perspective, is that we use the same terminology. We sing from the same hymn book. So we talk about something in an MDT setting, we use the same terminology. So for example, as you can see, you all must be familiar with the system. So for example, this particular lesion here is thought to be a 2R node. And when do you really think about or describe nodes as abnormal? It's an arbitrary thing which we use as a 1 centimeter cutoff, that if anything is thought to be above 1 centimeter on CT, we think of it as likely pathological. So this is an example of a 2R node, and that's an example of a subcarinal or station 7 node. Okay, so that brings us to the next thing, which is CT lung nodule assessment. Now, lung nodules are something that we incidentally pick up on any and every CT. It doesn't have to be done necessarily thoracic CTs. They maybe have been done for completely different reasons. And we do have a follow-up, what we call a virtual nodule clinic that we run in our trust and a lot of other trusts across the UK and I'm sure elsewhere. And the way we follow them up is, again, accepted local UK guidelines are the BTS guidelines, and the very similar to the Fleischner Society guidelines. Again, I don't want you to bore you with this very busy thing, but the ultimate aim of any lung nodule is to really assess size. And the second thing, the risks, and it's done by something called a Brock model. It's pretty straightforward. The lower risk groups and with a very small size, and we use the cutoff based on serial cutoffs there, and we offer surveillance. If you just remember, lower risk and smaller nodule, we offer surveillance. Higher risks and larger, we offer biopsy or intervention. So this is the current BTS guidelines. And again, without making it too busy or really wanting to go into the, into the depths of it, all I want you to know is that if it is thought to be stable, depending upon size, we continue to follow it up, and usually up to 2 years if it is a solid nodule. Obviously, it's slightly different for the subsolid in the ground glass, where we follow them up to 4 years. So that's an example of a nodule that was thought to be about 6 millimeters. It was thought to be followed up. At the end of 2 years, it remained exactly the same and the patient was discharged. Whereas the next case, which is again another 6 millimeter nodule that you see at the right base after 1 year, was thought to increase so much. As you can see, it's pretty crystal clear. This was amenable to biopsy and was found to be a carcinoma and subsequently had surgery. So that brings me to the next one. The next imaging modality is MR. We use it quite often, but not in every case, unlike the previous 2 imaging modalities. It's thought, well, it's mostly a problem-solving tool. So for example, if you had a pancreas tumor and there was a doubt about is there any vascular invasion, then we would go and proceed to do an MR, which is a bit more sensitive in that. Similarly, the same for mesothelioma. If you wanted to see diaphragmatic involvement, you would progress to do it an MR. So it's more a problem-solving tool and can sometimes be used for characterization. We use it quite routinely in our trust for thymomas. So because a lot of lesions, if they show a signal drop drop out are thought to be benign and not thought to be thymomas, and then they can come out of the MDT setting. Well, they have a huge advantage. They use no ionizing radiation, and Mr. Rathinam particularly uses them a lot for his pectus surgery patients. They're pretty good for anatomy for thoracic cage deformities. This is something we use routinely almost always in all our oncology imaging, which is PET imaging. PET imaging is a functional imaging modality for particularly oncology, thoracic oncology. We use FDG PET, which is really taking a glucose analog and you attach it to a radioactive tracer and you then send it out into the body, inject it into the body, and anything which is metabolically active will take it up. Now, it's got its limitation that it'll take it up, but doesn't tell you anatomy. So if you do it along with PET, you kind of synergistically take out the individual limitations of both the modalities. So and you can use it not just for initial staging, you can use it for evaluating the response to treatment, to restaging. In certain cases, such as mesothelioma, it's proven to be even prognosticating it, depending upon the standardized uptake value. And it's an upcoming modality for radiotherapy planning, although we are not using it in our trust. So I've already been through this, and now this is just a couple of examples of a T2 lesion, which is seen in the left lower lobe, and as you can see that it is showing high uptake. So usually anything which shows high uptake in the primary tends to show good uptake in the distal lesions, such as whether it's nodule or whether it's metastatic, and hence there is a certain limitation with adenocarcinoma, which can show slightly lower uptake, and that makes sometimes assessment difficult. So that's the same nodule that I'd shown you previously that was amenable to biopsy, and I had shown interval growth at 1 year. And as you can see on PET imaging, shows pretty marked uptake with no distal spread. So this was hence operated. The same case that I began with the right hilar mass lesion, was found to be a T3 on CT images, and then on PET images was found to be cavitating mass lesion. Okay, so that gives you a rough idea of all the imaging modalities that we tend to use for the preoperative workup towards surgery, or for in cases which are siphoned out of surgery. But really, radiology is a bit beyond diagnosis. It's for screening. We use it for prognostication. We intervene. It's also used in treatment and intervention. So I'll just briefly go through these. So let's talk about CT screening. CT screening is something which is up and coming in the UK, but it's all started with, all of you might be familiar with the National Lung Screening Trial, which was in USA with 50,000 participants with a 5-year follow-up. It was CT versus plain radiograph, and it showed 20% reduction in cancer mortality, which led to the Nelson trial, which is a bit more recent, which was CT versus no screening. It was with 13,000 participants, 10-year follow-up, and showed 24% reduction in lung cancer because of a lower stage at diagnosis, which currently is now in UK being shown in the lung health checks. And we've also had a pilot in 2016, and which showed a 1.7 prevalence of cancer in the participants. But here it was CT screening versus no screening. And in the NHS lung health checks, which has just recently literally been out, has shown a 2.5% cancer prevalence. So this is just, I mean, it's a really busy slide, but it's really showing the flow of participants through the screening service. I think for the benefit of time, I'm going to skip it, but really it just shows how you follow them up depending upon where you pick them up and what you think about it, whether they are positive, negative, or indeterminate. That brings up something local, which is a rapid access, I'm sorry about the spelling here, rapid access lung clinic. And that is something which is very local to Glenfield, where after you've picked up lesions, which are incidentally picked up, or you pick it up on a chest x-ray and you've done a CT, you actually discuss it with the surgeons, with the physicians, with the lung cancer nurses present, and then you really fast track it so that before the MDT, you've got most of the things already in place. So what are the things that we could actually physically put in place before the MDT? Most of the lesions, if they are amenable to biopsy, we try and biopsy them under CT guided. And of course, if they're chest wall lesions, you could do them under CT or ultrasound. Sometimes we use a lymph node biopsy of the neck for both diagnosis as well as staging to exclude N3 nodes. Okay. So where else can we benefit from biopsy? Well, the other thing which we use very often in this trust is that of using marking small lesions which are not palpable or may not be visualized on under VATS procedure. This has been going on for a long while, and we've actually published this in 2015 about a local experience with 50 patients, but they have been innumerable after that, where we mix the patient's own venous blood with methylene blue dye in less than 50% dilution, and mark the site extending from the level of the lesion up to the level of the pleura. Doesn't require any more expertise than knowing how to do a simple biopsy. Some centers use a via marking. We haven't used it here. So I'm going to just show you an example of a large right pleural effusion, which on CT was found to be large, but also showing quite a marked pleural thickening, which was biopsied under CT and then intervened by at the same sitting by putting a therapeutic chest drain. Another example that was shown previously of the right upper lobe nodule, which was then marked because it was thought that this can be removed under VATS procedure, but it was marked using same methylene blue venous blood mixture. And then this is how it looks like post. It almost looks the same picture like a ground glass, as though there's been a perilesional hemorrhage, and that was successfully removed. And this is what it looks like. I couldn't get some of our local images, so I have just taken this off. And as you can see, that's the lesion that needed to be marked. That's what it looks like superficially. And that's what the intraoperative view is. You just see the blobs out there which assist in surgery. Virtual bronchoscopy is something in the future. We don't quite use it here. And the idea behind it is that you basically do a volumetric acquisition of the whole thorax, get a virtual bronchoscopic appearance, and that would assist real-time bronchoscopy using ultra-thin bronchoscope. You literally have it running on the side. So you can see this is a virtual bronchoscope, and you have it literally guiding you as you go through it. This is literally the future, and especially where centers which are using ultra-thin bronchoscopes, level 3, level 6, level 7 level of bronchi. That's just something because we haven't done it there. I've just picked up a picture, which was a really beautiful example of something which was picked up on a virtual bronchoscope. It's just been marked out there. It was marked using using this virtual bronchoscopy. A marking was done. A subsequent CT showed good positioning of the lesion. This is exactly the intraoperative view, a fluoroscopic appearance of the same site, and that was the surgical specimen. So this is another thing that is not something that we're doing in our trust, but is being done widely across the UK, where you could do microwave ablation of small lesions which are not thought to be suitable for surgery. It's a thermal ablation using a microwave, but is done along the same tract as which you do a biopsy. And like I said, it can be used as an alternative to surgery for selected cases. It requires no more expertise than anything more than your CT-guided biopsy skills. So SABRE is something that is done by clinical oncologists in our trust, but I trained in India where radiotherapy was incorporated very much as part of radiology, and hence I put it here. But the only difference with the previous slide that I showed you about microwave ablation is that you use several beams of high-dose radiation, which are aimed at the tumor from different angles. And the bottom line is you basically use a CT to map the tumor location. So where do we come in terms of palliation? The two places where we assist locally in our trust is indwelling pleural drain placement and bronchial stents. Both the cases, indwelling pleural drain placement has now got a pleural clinic running as well. And in bronchial stents, you basically literally assist the surgeons by marking it, helping under the fluoroscopic guidance, pre-planning it with the CT. So I'm going to just show you a few examples of cases. Same case, if you remember from previously, where I showed a non-specific nodule in the right lower lobe, which on subsequent CT a couple of months later was shown to be significantly larger. When the CT was done, it was several PEs were seen. This is just a coronal MIP reconstructed images. The same nodule at that time, it was thought after this that we will treat the patient before doing anything further, because perhaps this is nothing but, because it's non-specific, maybe infarct. So hence a delayed 4-week CT was done, which showed, X-ray was done, which showed that the nodule was a bit larger. A subsequent CT was performed, which showed persistent of the pulmonary emboli. And then the CT at the same time showed that the nodule had actually become bigger and was spiculated, whereas on the contralateral side, there was what was confirmed to be an infarct. The same patient, you can see that by that time we had liver metastases and several bony metastases, and was not thought to be suitable for surgery. This is another patient which I've shown previously, large right hilar mass, which was shown to be actually thought to be a T2 lesion. On reconstruction, thought to be much bigger, T3 lesion. Had a PET which shows that there is internal cavitation and is quite PET avid, which at the time of biopsy was thought to be significantly smaller. And then it was decided not to proceed with the biopsy and do a follow-up CT. And on follow-up CT, as you can see, it disappeared. So at this kind of surgery was precluded really. A third case where you can see a large mass thought to be a mass lesion on CT. It's large, it's cavitating, it's spiculated. All the signs is thought to be PET avid, and subsequent CT, PET avid at that time, a subsequent pre-operative CT. We have a guideline here where anything which is outside a 6-week window prior to surgery, you repeat the CT, and on the pre-op CT, it was found to have disappeared. Same case, pre and then just prior to surgery. So I'm going to just finish this presentation by just talking about COVID, because we cannot not talk about COVID. Well, the important thing is CT is not used either to diagnose COVID because it's not thought to be as sensitive. But despite that, it's had a significant workload impact both on thoracic surgery and radiology. 2 reasons. I think there is no doubt that if COVID is found at the pre-surgical, or I would say in and around the surgical time, whether it's pre or post, you find that it's got a poor prognosis. So just locally, just at this time with this high COVID input that has happened, we have recently decided to still scan the patient just prior to surgery. And the other reason is it's got a high risk of thrombogenesis. So there has been a high request for CTPS during this time. There's no point showing what it looks like, although that's what it looks like on plain films as one of the common examples. But to be honest, it can look completely normal on chest x-rays to very, very profuse pneumonitis. This is literally just one picture, which is very commonly seen, and exactly what it looks like on CT. Really, that's really summing up my whole talk, just to give you a brief overview of the different imaging modalities that can be used and where radiologists could play a role in assisting the surgeons. So I'd like to thank you, and my biggest thank you is to one of my, believe it or not, third-year radiology colleagues who's helped me put these cases together in a very short time. And I'd like to add, he was actually a surgeon in his previous life and decided to become a radiologist. So thank you very much.